Today, my topic of presentation is about the prostatic urethral lift. Basically, we all know that benign prostate enlargement is a wide spectrum of disease. Depending on the severity, we have the management options, starting from the lifestyle modification, watchful waiting, to medical therapy, and then the invasive treatments. And starting with the introduction, this is basically a novel, minimally invasive approach and which can be done under local or general anesthesia. The encroaching lateral lobes of the prostate are compressed by small permanent suture-based implants delivered by cystoscopic guidance by a device called Urolift. It is made by a US-based company which results in the opening of the prostatic urethra. We will see in the animation video later how it works. It basically leaves a continuous anterior channel through the prostatic fossa ranging from the bladder neck to the verumen canal. It achieves quantifiable improvements in the functional outcomes and quality of life in the absence of major adverse effects as compared to the other modalities, and also preserving erectile and ejaculatory functions. This is basically a device. Lens is passed through this as we use in the cystoscopy. 0-degree lens is passed, and this is basically the prostatic implant. It has two sides. This one is the capsular side, and this is the urethral side. This is made of nitinol, and this is made of stainless steel, and this is a non-absorbable suture, mostly made of nylon. As I already explained, it is a device with lens passed through it, and it's performed endoscopically. And it is designed as such that a single prosthesis made of capsular nitinol tab and a urethral stainless steel bridge by a non-absorbable nylon suture. This suture is kept under tension, which draws the prostatic urethra to the prostatic capsule, and in this fashion the channel opens. I would like to show an animated video. So it better explains how it works. This is a cystoscopic vision, endoscopic vision. As we enter into urethra, this is the enlarged prostate. Now this device enters into the prostatic urethra. On either side, it pushes the prostate into the, and this implant then, depending on the size of the prostate, you can insert multiple on either side. As we can see, a significant opening of the prostatic urethra, and the channel is created, which helps in the further. Now come to the literature review, how much it has improved the different factors. It basically achieves a significant improvement in the IPSS, Qmax, and the quality of life. Another study was done, LIFT study, which was a multi-center study comparing posterior urethral lift with the sham with 5 years follow-up. It's the longest study which has done. The primary endpoint, which was met at 3 points with a 50% reduction in AUA symptom index score from 22 to 11 points, which means it's severe to the moderate and remains stable up to the 12 months. Qmax significantly increased from 8.1 to 12.4 ml per second at 3 months, and this result could be confirmed at 12 months as well. Improvements in IPSS, quality of life, and BPH impact index and Qmax were durable throughout 5 years, with improvement rates of around 36, 50, 52, and 44% respectively. The retreatment rate was about 14% over 5 years. Adverse effects were mild to moderate and were transient, which was not long lasting. And the main benefit and advantage of this procedure that sexual function was stable over 5 years with no de novo and sustained erectile or ejaculatory dysfunction. And another RCT of 80 patients were conducted in the 3 European countries, comparing prostatic urethral lift to TURP. At 12 months, IPSS improvement was minus 11.4 for PUL versus 15.4 for TURP. But there was no retrograde ejaculation among PUL patients, while about 40% of patients which has TURP lost the ability to ejaculate. So it is a huge difference and a huge advantage of PUL over TURP. Recovery was also more rapid and more extensive in 3 to 6 months. However, the TURP resulted in much greater improvement in Qmax after 1 year as compared to PUL. We can see that 13.7 plus minus 10.4 ml as compared to 4 into 4.5, 4.8 in PUL group. After 2 years, the significant improvement in IPSS, quality of life, BPH impact index and Qmax were observed in both arms throughout the 2-year follow-up. But changes in IPSS and Qmax in the TURP were superior to PUL. In a meta-analysis of retrospective and prospective trials, pooled estimates showed overall improvement following prostatic urethral lift, including IPSS 7.2 to 8.7 points, Qmax 3.8 to 4 ml per second, quality of life 2.2 to 2.4 points, and the sexual function was preserved with a small improvement estimated at 12 months. The Qmax improvement is basically clinically significant and compared with the patient satisfaction, it was clinically significant. But as compared with TURP, it is less superior. The complications which we discussed with PUL was most transient and about last 2 to 4 weeks, which includes hematuria, dysuria, pelvic pain, urgency, transient incontinence and UTI. And there is almost no sexual dysfunction or ejaculatory dysfunctions. The limitations with this procedure, we cannot do with the enlarged median lobe and prominent bladder neck. The prostate size is variable. The guidelines, EU guidelines mention 70 ml, and most of the literature mentions around 100 grams, depending on the expertise of the surgeon. And result accordingly varies with the size of the prostate. This is basically a summary of evidence from the EU 2019 guidelines, which states that prostatic urethral lift improves IPSS, Qmax and quality of life However, these improvements are inferior to TURP at 2 years, as we already saw the randomized controlled trial. And the level of evidence is 1A. Prostatic urethral lift has a low incidence of sexual side effects. Again, the level of evidence is 1A. Patients should be informed that long-term effects, including the risk of retreatment, have not been evaluated. And they recommended that offer prostatic urethral lift to men with LUTs interested in preserving ejaculatory function with prostate less than 70 ml and no middle lobe. I would like to show another video, surgical video. There is no sound. You can see it's an easy, short duration procedure which can be performed under general or local anesthesia with mild sedation and very less intra-op complications as compared to TURP. Even post-op complications are very transient and less as compared to TURP. We are here into the prostatic fossa. This patient is basically already had a TURP. That's why this median lobe is not enlarged. You can see it's compressing on the ipsilateral side, and we can see the implant is passing through this. And you fire the gun with the device, and this prosthesis is implanted into the urethra. Minimal bleeding, and most of the patient does not require any post-op catheters. Prerequisites are that there should be no median lobe enlargement, and the bladder neck should not be higher. Once earlier literature shows that it has a limitation that patients with severe BPO and those with urinary retention are also excluded from this procedure. But the study which we show later, they have done in the severe BPO category, and the results are variable. We'll see later. It has a minimal hematuria, so it is fulminated by the electrode. As compared to TRP, this. Now coming to the article, it is basically a multi-German center evaluation after 2 years. It is a minimally invasive prostatic urethral lift efficacious in TURP candidates. They basically selected those patients which are already planned for TURP. Starting with the introduction, as we all know that TURP is the gold standard treatment for the moderate to severe LUTs or failed medical therapy. It has a significant long-term improvement in the clinical outcomes and low retreatment rates after 10 years after intervention, with a very significant side effect profile. Reported peri-operative and long-term complications, as we already know, that bleeding, acute urinary retention, clot retention, UTIs, and severe sexual dysfunctions like erectile and retrograde ejaculation, and others are usual stricture and bladder neck stenosis. So, due to this, there are different technologies are developing, innovative. Already we are discussing over past month, like radium and other technologies, and PUL is one of that, to relieve the patient symptoms and avoid the complications, mainly the sexual complications. As we already discussed, it is a novel, minimally invasive therapeutic option for the treatment of moderate to severe LUTs, which is performed without a tissue removal or involvement of the inner sphincter. They basically hypothesized that this is the less invasive PUL could be a successful substitute for TURP, even if the BPO was severe. Therefore, they investigated the outcome of PUL in an unselected population of benign prostatic obstruction who had already been deemed to candidates for TURP. Materials and methods. Basically, the men treated for low intake symptoms during the period of October 2012 to the 2014 Jan at 5 German urology departments. Data were retrieved from the prospectively designed database. Patients with confirmed moderate to severe DPO-related LUTs that were unresponsive to oral therapy were considered eligible for PUL if they were candidates for surgical ablation or TURP. All the patients underwent cystoscopy, transrectal examination and ultrasound examination before surgery. And the exclusion criteria, as we already discussed, was an obstructive median lobe seen during the initial cystoscopy. Follow-up visits were scheduled at 1, 6, 12 and 24 months post-operatively. And the QMAX, PVR, IPSS 0 to 35 and single related quality of life question, which were assessed at the baseline and each follow-up visit. And all patients were evaluated for sexual functions from their baseline. Coming to the results, 212 patients were eligible for TURP, but out of that 60% were eligible of the PUL procedure, because rest were excluded due to median lobe, prominent median lobe and prominent bladder. And 86 patients of the 138 patients are included because rest were procedure for TURP. We can see the results. The baseline IPSS started from the 22 and there is an improvement around at the 10 after 24 months, basically showing the 24 months there is significant improvement in the IPSS. Similarly, in the quality of life, it ranges from the 4.4 to the and improved to the 1.5. We can see here, starting the baseline 4.4, which is, as I think most of the resident knows the IPSS and the quality of life questionnaire. The 22 lies in the severe category, and the improvement is basically 12. 0 to 7 we label mild, 7 to 18 is moderate, and 18 above is the severe category. And quality of life, we have start from the 0 to 6. 4 is basically the mostly dissatisfied, and 1 is basically most of the time happy. And the baseline PVR is around 150 ml, and the improvement is around less than 60 at 24 months. The QMAX, the starting QMAX, the baseline is around 11, and the improvement reaches up to the 16, with plateau reaching around more than 14. The patient characteristics, basically age, the mean age is around 66, range from the 38 to 85 years old. prostate volume ranges from 17 to 111. The mean size is 43. As we discussed, the size, as the results depend on the size of the prostate also. As the size of the prostate enlarges, the results get much lesser. Operative time is basically depends on the 42 to 90 minutes, and the mean is the 57. Number of implants per patient is, the mean is 3.8, ranges from 2 to 7. 14 patients they have previously catheterized pre-op, which is failed trial, and 33 patients out of 86 patients already on the medical treatment. 33 patients basically in this group has severe BPO of the 86, and the severe BPO is characterized by the high PVR more than 250 ml, and the prostate size is more than 60 ml, and third is the severe QMAX, deranged QMAX. This is basically at the showing the baseline and the follow-up at 1 month, 6 months, 12 months, and 24 months. We can see at the baseline the mean IPSS score was around 20, plus minus standard deviation 6.5. At 1 month there is significant improvement, it comes around 12. At 6 months, almost similar result. At 2 years follow-up, the significant improvement clinically we can see from the p-value with sustained results. It does not deteriorate over the period. Similarly, the quality of life at the baseline 4, which is mostly dissatisfied. Over the period at 1 month and 6 months, the quality of life increases. 2 is happy, and sustained over the period of 24 months. And we can see the p-value is clinically significant. PVR at the baseline was around 150, and over the period follow-up 1 month, we can see it's a significant improvement. It is not clinically, it's not significant, but it has improved. And at 12-month follow-up, we can see there is a significant improvement. Similarly, QMAX, baseline it was 11, and at 1 month it's around 15, and which is almost sustained over the period with clinically significant p-value. This table is showing basically the subgroup which has the severe BPO. As I already told that high PVR and large prostate size and a bladder capacity of more than 50% estimated. Coming to the discussion, we can see that in the IPSS there is a significant improvement over the period, follow-up period up to the 2 years, ranging from the 20 to the coming into the less severe group. Similarly, the quality of life starting from the 3.7 to the happier group, from the dissatisfied group to the happier group. PVR overall does not significantly improve over the period, because the reason they gave is the hypercontractile detrusor, and they suggest that the patients which have an overall enlarged PVR should undergo either a catheterization prior to the procedure, or they should undergo a urodynamic evaluation before undergoing the PUL procedure. And the QMAX similarly increases from the baseline 9.5 to almost 14 over the period. As we already discussed the efficacy and the benefits of the procedure, and we already discussed the comparative studies the lift study, which is basically done to basically get the approval for the device by the FDA. The PUL is a efficacious treatment for the men with moderate to severe symptoms, IPSS more than 12, Qmax less than 12 or 15, and low residual volume less than 250 ml. This investigation shows that the PUL may also be appropriate for men with later stage prostatic obstruction, as defined by the urinary retention, elevated PVR or larger prostate. 14 patients presented with Foley's catheter with unsuccessful trial to void. 12 men in the urinary retention were successfully weaned off from their catheters post-op and remained catheter-free at the last follow. One of the two treatment failures also failed to void after follow-up with URP, resulting in the chronic suprapubic catheterization. 3 of the 7 patients with high PVR at the baseline underwent URP. The initial experience suggests that PUL should be reserved to patients for the functioning bladders. If the patient presents with high PVR, very high PVR, we would recommend a period of catheterization to stabilize his bladder function and a urodynamic evaluation. The conclusion of this study, basically, this is the first report of the outcome of the PUL and offered to all patients. Initially, the studies were done which have, as I told, that patients without catheter and patients have mild to moderate loads, but they have included the patients with severe loads as well, and even with the indwelling Foley's catheter. This basically the procedure yielded satisfactory results that were consistent with the previously published tightly controlled study populations. 86% of the men presenting with retention were freed from the catheterization, but 2 with very high PVR were not. However, this may be related to a hypocontractile detrusor muscle. For men presenting with high residual volume, urodynamic characterization of detrusor contractility and preceding PUL with a period of catheterized drainage may be advisable. This data could encourage clinicians to consider offering PUL therapy to a broader range of QRP candidates.
Right, so for the past 2 months we have been discussing benign prostatic hyperplasia, and as we have already planned that we want to cover as much of the subject as possible, because it's a lengthy subject starting from pharmacotherapy till surgical therapy. There are controversies, yes, there are certain things which are not recommended, but there are some suggestions which are valid suggestions, and there are certain guidelines. So there are, I think there is a transatlantic difference of opinion between North American guidelines and European guidelines, but every country has got its own say right to devise a new strategy for their own people. For instance, if anybody in Pakistan, any center wants to devise its own strategy, then everybody is welcome for it. So guidelines are for the guidelines. They don't impress upon you to put your patient into a guideline and then treat it. Your patient is your patient. Whatever you want to have for your patient, there has to be an ownership, and the ownership doesn't start with the treatment, it ends somewhere with the complications and also with the prognosis of the disease. So that is my understanding of the subject of medicine. So if we have got a wish list, so this is the kind of a wish list which was presented last 6 months back in one of the meetings, and it takes into consideration a lot of things. For instance, histotripsy. Now, what is histotripsy? What I can understand from this topic is it is just like a lithotripsy. So histo concerning with living cells. So if you have got an energy modality which can break the stone, energy modality which can do away with cells, prostatic cells, then this is histotripsy. We haven't got into the details of histotripsy, but this is one of the things. InnoFlow is one of the things which is probably more in fashion in Europe, and this is the same thing as way back. Said would bear me out. We had got one treatment for non-functioning kidneys, and that is injection of alcohol. So this is the same thing: injection of alcohol into or some toxic material into the tissue, and that is prostate. So we have got a lot of things there. We have, I think, covered a lot of them. Maybe a few are left. So let's see what the guidelines say. Starting with the AUA guidelines, the North American guidelines. It was presented in 2018, but amended, slight bit of modification in this year, 2019. For surgical therapy, the statement is it is recommended for patients who have renal insufficiency secondary to BPH. So this is slightly different because this is their own perspective. Refractory to urinary retention secondary to BPH, recurrent urinary tract infections, recurrent bladder stones or gross hematuria due to BPH and or with LUTS attributed to BPH, refractory to and or unwilling to use other therapies. So this is the clinical principle on which they want to treat their patient. I would rather be very fast because we have to cover a lot of slides. The second statement is clinicians should not perform surgery solely for the presence of an asymptomatic bladder diverticulum. So this is very important because they are seeing their patient on a wider scale. They have got, I think, the largest number or the ratio of urologists per patient according to their own say population. So they can see these things in greater details. However, evaluation for the presence of bladder outlet obstruction should be considered. So this is the second clinical principle. There is another statement which says that for TURP, transurethral resection of prostate should be offered as a treatment option for men with LUTs attributed to BPH. So they have got their own level of understanding according to their evidence level. So this is a grade B evidence level. The second statement is transurethral resection of prostate. Clinicians may use a monopolar or bipolar approach to TURP depending on their expertise with these techniques. So this is the same, I think, the thing that we apply here. For those who are not familiar with using a bipolar instrument, it's better to start with a monopolar instrument. But yes, there are indications for both. The standard of care should be bipolar because it confines the electrical current to a single point. The current circuit is not wider, so there is less damage, and you can use it with saline, so there is no TUR syndrome. So we have got benefits and complications going side by side. Prostatectomy, simple prostatectomy. Clinicians should consider open, laparoscopic or robot-assisted prostatectomy depending on their expertise with these techniques for patients with large prostates. Now, what's the definition of large prostate? Everybody has got its own definition. For instance, there is a mention in the literature where they say that a larger prostate is greater than 150 grams. Now, somebody can say that it is like greater than 100 grams or maybe 90 grams. Again, it depends upon the technique employed and the kind of experience that you have. You can use monopolar or bipolar TURP for the purpose of dealing with a bigger prostate. But the thing is, you are actually, if you are a novice or an inexperienced person, you are actually inviting a lot of complications. So the complication should be at the back of the mind of anybody, maybe a senior, maybe a junior, that this thing can happen with bigger prostates. For instance, if you have got a smaller prostate, less than 90 gram, would anybody confirm that this patient will not have TUR syndrome? No, because if you increase the amount of fluid used, if you increase the amount of time you have spent, even you can create TUR syndrome in a 30 grams prostate. So it depends upon the technique and certain limitations which are scientific limitations. Transurethral incision of prostate should be offered as an option for patients with prostates less than or equal to 30 grams for the surgical treatment of LUTs attributed to BPH. Transurethral vaporization of the prostate bipolar TUVP may be offered to patients for the treatment of LUTs attributed to BPH. Again, it depends upon the armamentarium that is available to you. Any center in the world cannot have all the things available within a single setup. There are certain things which are available in one center. There are certain which are available in the other center. So it depends upon the experience that a surgeon has with certain treatment protocols. Photoselective vaporization of prostate. Clinicians should consider PVP as an option using 120 watts or 180 watts platforms for patients for the treatment of LUTs attributed to BPH. Now this is prostatic urethral lift. What they say about it, clinicians should consider PUL as an option for patients with LUTs attributed to BPH provided prostate volume is less than 80 grams and verified absence of an obstructive middle lobe. So there should not be any middle lobe. However, patients should be informed that symptom reduction and flow rate improvement is less significant compared to TURP. Patients should be informed that evidence of efficacy and retreatment rates are poorly defined. So we need a little bit of randomized control trial in this setting. PUL may be offered to eligible patients concerned with erectile and ejaculatory function for the treatment of with LUTs attributed to BPH. So this is a level evidence C. Now Manzusa was explaining about this thing TUMT, and to his opinion, he says that TUMT is now out of fashion, but till 2019 AUA guideline TUMT is still on the horizon. It can be offered to patients with LUTs attributed to BPH. However, patients should be informed that surgical retreatment rates are higher compared to TURP. So these are indicated, this treatment is indicated only for those who have got comorbidities, for instance arrhythmias, for instance anesthesia. You can't do procedure in general anesthesia or spinal anesthesia. TUMT is available for them, which is done under local anesthesia. So what about water vapor thermal therapy? Water vapor thermal therapy, this is a reason, can be offered to patients with LUTs attributed to BPH provided prostate volume is less than 80. However, patients should be counseled regarding efficacy and retreatment rates. So whenever somebody is giving or counseling a patient regarding a treatment, two things should be explained. One is retreatment. Nobody wants treatment time and again. Everybody wants treatment once and for all. So this has to be explained. Water vapor thermal therapy may be offered to eligible patients who desire preservation of erectile and ejaculatory function. So this is very important. For instance, if somebody wants to have a child in future, you can't predict, or maybe you can't say guarantee that person that after TURP you can have, because there is retrograde ejaculation. So this is one big advantage with reason. Transurethral needle ablation tuna is not recommended for the treatment of LUTs attributed to BPH. So it is out of the list. Laser enucleation of prostate. Clinicians should consider holmium laser enucleation of prostate or thulium laser enucleation of prostate depending on their expertise with either technique, as prostate size independent suitable options for the treatment of LUTs attributed to BPH. So the way forward now at the moment, as this conference of WCE is going on in Abu Dhabi, there is a big debate between HOLAP and TULAP. So thulium maybe is the way forward, but because it has got certain advantages as regards the diameter of the fiber which is used for TULAP or for thulium rather than HOLAP. So we'll be discussing these things in the second round next year when we talk about BPH, because then everything will be settled. Aquablation. It may be offered to patients with LUTs attributed to BPH provided prostate volume is greater than 30 or less than 80. So it gives you benefit within this range. However, patients should be informed that long-term evidence of efficacy and retreatment rates remains limited. Prostate artery embolization, PAE, is not recommended. Again, I should repeat, PAE is not recommended for the treatment of LUTs attributed to BPH outside the context of a clinical trial. So this is not available for any patient without counseling or without having signed the trial document. So it is still on the trial, but this treatment is available in Islamabad these days in Shifa International. So there are patients with medically complicated conditions. HoLAP, PVP, TheoLAP should be considered in patients who are at higher risk of bleeding, such as those on anticoagulation. So this is a kind of a paradigm that we have also. For instance, if there is a patient who has got ITP and you want to do away with prostate, so you are in a fix what treatment that person will have, because thrombocytopenia will always hinder your advance of any treatment. So if you have got laser treatment available, you can offer these patients this kind of a treatment. Now coming back to Europe, what the European guidelines of 2019 says about it. Europe has got a limited sort of a version. For instance, for TORP, recommendation is strength rating offered transurethral incision of prostate to surgically treat moderate to severe LUTs in men with prostate size less than 30. Again, this is same. TOIP is for prostates less than 30 without a middle lobe. Strong offer for bipolar or monopolar transurethral resection of prostate to surgically treat moderate to severe LUTs with men with prostate size of 30 to 80. So if you have got like 30 to 80, you go over to TORP rather than to TOIP. Strongly offer plasma bipolar transurethral vaporization of prostate. We have discussed what the plasma technology is as an alternative to TORP to surgically treat moderate to severe LUTs in men with prostate size of 30 to 80. So there is a strong recommendation for it. What about open prostatectomy? In Europe, the recommendation is endoscopic enucleation of prostate or open prostatectomy to treat moderate to severe LUTs in men with prostate size greater than 80. So now the paradigm is shifting towards greater than 80. What you have got, you can do both. You can do enucleation or you can do open prostatectomy. Strong offer open prostatectomy in the absence of endoscopic enucleation to treat moderate to severe LUTs in men with prostate size greater than 80. Now mind you, there are two terms. One is enucleation, the other one is resection. There is a comparison. What is enucleation, what is resection? We haven't talked about it, but if you want to, we can talk about it later. If you want to compare endoscopic procedure with open procedure, then it has to be enucleation rather than resection. Now the summary of evidence of recommendation for HoLAP and LRP. LRP means for instance, E means enucleation, R stands for resection. So holmium can be used for both. The technique is slightly different, but the technique which differs is actually for the bigger prostates. For instance, for bigger prostates, you don't want to resect, you want to enucleate, just because of the reason that TOR syndrome should not be there. Now for 532 nanometer green light laser vaporization of prostate. This is something which was not considered in the AUA guideline, but is something which is strongly practiced and strongly recommended in European guidelines, and they have got a lot of experience with it. Diode laser treatment of prostate. Recommendation is 120 watt 980 nanometer diode laser vaporization of prostate to men with moderate to severe LUTs as a comparable alternative to transurethral resection of prostate. So it is a comparable alternative. So if you want to have a comparable alternative for TORP, then it is diode laser. If you want to have a comparable alternative to open prostatectomy, then it is something which is HoLAP, holmium enucleation of prostate. Now thulium, as I have said earlier on, we haven't discussed about it, but we'll be discussing in the coming future. What about prostatic stents? Recommendation is, it is an alternative to catheterization in men unfit for invasive procedure requiring spinal or general anesthesia, but the recommendation is a weaker recommendation. Prostatic urethral lift, it is recommended to patients with LUTs in prostate in preserving ejaculatory function and in prostates less than 70 and no middle lobe. Intraprostatic injection, this wasn't there in American guidelines, but this is there in European guidelines. They say that if you have a botulinum toxin A injection, then it can be used in patients with LUTs, and recommendation is strong in Europe. For all these different kind of newer techniques, for instance, like laparoscopic robot-assisted simple prostatectomy, TIND, we have discussed about it. This is a nitinol, say, device which is used for the prostatic urethra to expand a little bit. Aqua ablation, image-guided robotic water jet ablation, convective water vapor energy, as we have seen in RESUM, and prostatic artery embolization. These are not recommended. The recommendation, the simple, say, the clinical statement for these is, these new interventions will only be included in guideline once supported by RCTs with adequate follow-up. And since there are no RCTs, enough RCTs available, so in Europe, all these treatment modalities are not recommended. So that's all.